We are waiting for Dr. Indu to join and Matthew sir, I
डॉक्टर
think
जोसेफ, हाँ जोसेफ
Dr.
जोसेफ।
Joseph has joined.
हाँ सर, आपने ज्वाइन किया सर?
Yes, sir. Sir has joined. Just wait for a minute and then we will start.
Sir, good evening, sir.
Dr. Kasi, good evening.
गुड
Welcome.
गुड इवनिंग डॉक्टर
Good evening.
काशी। गुड इवनिंग।
Hi, sir. How are you, sir?
फाइन फाइन।
Very fine.
Dr. Ajay, can we start, please?
हेलो।
Yes,
हाँ।
Dr. Ajay,
यस सर, यस सर, हाँ।
can we start, please?
ओके सर। So, good evening, and I welcome all of you in this 12th episodes of IAP NRC General Club. And today, this 12th episode is the last episode of this year, and also this is the last episodes in the chairmanship of our Dr. Rawat sir. All of us know this General Club is the brainchild of our visionary Dr. Rawat sir, and his chairmanship in the 2025. This was started in the January. This gives us a very good platform for the PG students and the residents and even the faculty to discuss the any articles and know the methodology from our eminent teacher like Dr. Joseph sir, Dr. Indu Khosla ma'am, and many other session expert that we are inviting in our journal club. So this is a very flagship program of our chair and under the leadership of our chairman sir, and I invite Dr. Rawat sir for a few words regarding this general club, sir. Rawat, sir.
Thank you, Dr. Ajay Kumar, and good evening and a warm welcome from IPNRC. Respected Dr. Joseph, Dr. Ajay Kumar, the expert for today's session, Dr. Premila Paul, Dr. Sarath Balaji, Dr. Saktivel, who is the presenter, all my dear EB colleagues and dear friends, and all the delegates who are there on board. First of all, I'd like to thank all the delegates who have been there with us for this journey for the past 12 months, where we started the first journal club in January 2025. And now this is the last presentation of this particular year. How this program started was that when I was planning my presidential action plan, we were very clear that we must do something substantial for our residents, for our postgraduates, and of course for our members, because critical appraisal of an article is very vital to extract important information. And how to do a critical appraisal and how to analyze the data and how to come to a conclusion whether this particular information is of use or not. This required a quite a rigorous method which should be appropriate and taught out to all. So I talked to Dr. Indu and Dr. Matthew, and I'm thankful for both of these senior Padmavajs that they had agreed for this session, particularly Dr. Indu to be with the chairperson for this particular session where she took the initiative, and of course without the help of Dr. Joseph Matthew, because he's an expert researcher, a very avid follower of evidence-based methodology and evidence-based research, and he's the main resource person where he gives very critical input regarding all the articles which we have discussed. And we really hope that whatever discussion has occurred in the past 12 months, this have been useful to all of you. I particularly thank Dr. Ajay Kumar for his perseverance, because he every month he used to follow up various institutes where he used to talk to them, and he has to decide what article to be presented. And I am happy to announce that all articles presented in the past 12 months were excellent. The discussion went on very well, and we really hope that all the delegates must have got very important message. So, with this last edition of Journal Club, we hope that the incoming executives in the next year in 2026, they'll continue with the same zeal. And I'll request the team of Dr. Indu, Dr. Ajay, and Dr. Joseph sir to continue to guide us, lead us in the world of evidence-based research. So thank you very much for being with us. And today we are having a very interesting article on Montelukast, the side effect, because FDA in way back about 15, 20 years back, they had given a black box warning regarding the use of Montelukast and its side effects. But again, the evidence was scanty. So I think this is a very long time. This was very well needed. That is there any evidence of neuropsychiatric problems related to Montelukast? So this article would give us an insight regarding what is the actual situation. Although it is an retrospective analysis, which is uh, observational, which has got a lower grade of certainty and low grade of evidence in the hierarchy of evidence. But definitely this is one of the evidence where at least something would move forward. So let us see the article, and I'll request Dr. Ajay Kumar to again take over and start the session, please. Thank you very much.
Thank you, sir. Thank you, sir. And thank you, sir, for giving me opportunity as well as the another companion of my seniors, Dr. Indu ma'am and Dr. Joseph, sir. Hopefully, we will continue in the next year with the same zeal and same curiosity. So, thank you, sir, again. And now I welcome Dr. Indu ma'am, our coordinator, Joseph, sir, our national expert, as well as our session expert, Dr. Pramila Paul, ma'am. Ma'am is at present senior consultant and pulmonologist in the Rainbow Hospital in the Delhi. But ma'am is also ex-professor of Department of Pediatrics in Safdarjung Hospital. So ma'am has very keen interest in the clinical and as well as in the this articles and academics. And I also welcome Dr. K.S. Saktival K.S. He is a pediatric pulmonology fellow in the Institute of Child Health in the Madras Medical College, as well as this. I also welcome session mentor Dr. Sarat Balaji. Sir is also associate professor in the Institute of Child Health, Madras Medical College in the Department of Pediatric Pulmonology. So with these words, now I hand over the session to Dr. Indu ma'am to take carry forward. Ma'am, please.
Yeah. Thank you so much, Dr. Ajay Kumar. I need to say that though the idea of starting the journal club was probably I initiated it, but I don't think it would have happened unless Dr. Ajay and Dr. Rawat took it forward, and with the persistence and zeal that they take it forward. That's the reason why this whole program has seen the light of day, and I hope and pray that it continues because it has given us a lot of insights, especially Dr. Joseph Matthews has taught one and all of us how to really, kind of interpret articles in the correct light. I welcome Dr. Pramila, Dr. Sarat Balaji, and the speaker, Dr. KS. I hope I'm pronouncing your name right. I will keep it at Dr. KS for now. For this very interesting topic on Montelukast. Whenever the list of articles come to me to select which article has to be, which topic has to be taken, though of course the whole plan is to see how the article has been written, and Dr. Joseph Matthews every time emphasizes it should be, you have to just focus on what has been written. But sometimes I'm tempted to get an answer for some other things that we routinely face in practice. So therefore, I got a little bias to select this article, and I hope we look at both the options of analyzing the article and probably taking home some messages. Over to you for your presentation, Dr. K.S.
Thank you, ma'am. Thank you, sir.
Yeah. Can you tell me how do you Sakti well, right? Is that correct?
Yes, ma'am. Shakti Vel.
Shaktivel. Okay, that's easy. Okay, thank you. Over to you. Yeah, we can see your slides. Yeah.
Thank you, ma'am. Good evening, everyone. So, myself, I'm Dr. Shaktivel, a pediatric pulmonology fellow from Department of Pediatric Pulmonology from Institute of Child Health and Madras Medical College. My mentor is Dr. Sarath Balaji, sir, Associate Professor of Pediatric Pulmonology from ICH and Madras Medical College. The journal we are going to discuss today is Montelukast use and the risk of neuropsychiatric adverse events in children. It was published in JAMA Pediatrics in January 2025. The authors are various authors are from the Karolinska Institute, Stockholm, Sweden. So the background, Montelukast is an oral, just a minute. Yeah, thank you. So Montelukast is an oral leukotriene receptor antagonist widely used in children for asthma and allergic rhinitis as an add-on therapy. The safety signals started in 2008 as individual case reports mostly, which linked Montelukast to anxiety, depression, sleep disturbance, aggression, and suicidality. Based on this, FDA added an boxed warning in 2020 advising caution, especially for mild disease. But in pediatrics, the evidence is scarce and mostly inconsistent. So the key unknowns before this study were the magnitude of neuropsychiatric adverse events, specifically in children, if it is associated, and whether the risk differs by age, sex, prior psychiatric history, or indication, and temporal patterns, early onset after initiation versus delayed events. So the research question is, among children aged 6 to 17, is current Montelukast use associated with an increased risk of neuropsychiatric adverse events compared with use of long-acting beta agonist? The objective is to investigate whether the initiation of Montelukast in children and adolescents is associated with an increased risk of neuropsychiatric adverse events compared with the initiation of long-acting beta agonist using a national-wide register-based cohort study. So the population is, as previously mentioned, children and adolescents aged 6 to 17 years receiving routine clinical care with no documented neuropsychiatric adverse events at baseline. The exposure is current use of Montelukast defined as incident initiation and analyzed using an as-treated approach. The comparator is current use of long-acting beta agonists defined as, again, incident initiation, serving as an active comparator. The outcome is composite neuropsychiatric adverse events, including anxiety, depression, sleep disorders, suicide or suicidal actions, disrupted control of activity, attention, behavior, and confusion or psychotic-like symptoms. These outcomes ascertained via specialist diagnostic codes and also selected psychotropic drug dispensing as a proxy. The follow-up from treatment initiation till outcome occurrence or treatment discontinuation or switching, death, migration, or for a period of maximum of 1 year. So this was modeled in discrete 14-day intervals. So the study design overview. So they used an nationwide register-based retrospective cohort using 3 registers: Swedish prescribed drug register, national patient register, total population register. The design is an active comparator new user cohort. So why was this design chosen? So what does it mean? So in an active comparator, the adverse event caused by a drug is compared with another similar drug instead of comparing it with a placebo. So this is done to minimize the confounding by indication, because when we compare a drug with a placebo, the patient population might be different, who will be actually needing the drug and the placebo. So to minimize the confounding by indication and to also minimize the disease severity bias and health system contact bias. So for the last two is the reason why LABA was chosen. So when we compare both LABA and Montelukast, both are an add-on therapies for asthma and prescribed at a relatively similar disease stage, reflecting a similar healthcare seeking behavior. And the reason why new user cohort was chosen instead of a prevalent user was to avoid survivor bias. In a prevalent user, the early adverse events may be missed, and most of the prevalent users who are continuing to use an Montelukast or any drug, they might be survivors of the early adverse events. So using them might lead to a survivor bias. So to ensure correct temporal alignment of the exposure and confounders and to capture the early adverse events that would be missed in a prevalent user cohort, this study used an incident users. So the exposure definition is that incident dispensing of montelukast assume and the treatment is considered to be continuous until no refill within assumed duration with a 60 days grace period. Alternate grace periods with 30 days and 90 days were also sensitivity analysis was done for this alternate grace period also. The comparator is an incident LABA initiators, and censoring was done for patients for whom, for example, in the montelukast group in whom LABA was started, or LABA group in whom montelukast was started, or montelukast patients who stopped medications or were lost to follow. So the outcome definition were any new, like previously discussed, any adverse neuropsychiatric events, including anxiety, depression, sleep disorders, suicide, suicidal actions, disrupted control of activity, attention, behavior, confusion, psychotic-like symptoms. So this assignment is based on specialist care diagnostic codes from the previously said registers, and these codes were mentioned in the supplementary data. Secondary analysis was done for each individual of these neuropsychiatric events, and also for situations where only drug dispensing was used as a proxy for the diagnostic code. This was done actually mainly for sleep-related disorders where drug might be dispensed even before them being documented with certain diagnostic codes. To prevent missing of this patient, they used even dispensing of certain psychotropic drugs as a proxy for these adverse events. But the caveat is that register-based diagnosis have established, even though they have established validity for many psychiatric codes, their sensitivity might be vary for internalizing symptoms. So the statistical methods used in the study were, like previously said, active comparator new user design was used with an as-treated analysis, aiming at the average treatment effect in overlap population, propensity score overlap weighting for confounding control, inverse probability of censoring weighting for informative censoring, pooled logistic regression on 14-day intervals were used. Covariates that were analyzed were socio-demographic, calendar time, indication proxies, prior medications, comorbidities, and healthcare utilization. Like previously mentioned, the sensitivity analysis was done for alternate grace period, 30 days and 90 days. Also it was done for overlap weight versus inverse probability of treatment weighing, and also they compared between no censoring of weights and alternate outcome definitions and secondary outcome checks. So we'll be decoding this statistic techniques used as treated analysis, and this we will be discussing in the subsequent slides. So first, as treated analysis. So in the as treated analysis, we analyze the participants based on the treatment they actually receive at any given time. Follow-up is censored upon discontinuation or switching. So this follow-up being censored upon discontinuation is one of the weakness in this study, which may actually lead to informative censoring. Meaning, when the follow-up is censored on discontinuation, this discontinuation may not be a random event. This discontinuation may be due to an early adverse event. When censoring is done for these patients, if these patients develop an adverse event in the follow-up, we may miss this, and this may lead to an null bias, meaning it may be falsely showing as in the adverse events are not much. So to prevent this information censoring, the technique used is inverse probability of censoring weight. So the meaning of this is that so to avoid the patients who are censored due to whether stopping of medication or loss to follow-up, is that what they did is, based on the covariates in the remaining patient population, they gave more weight to children, uncensored children, and these uncensored children who were similar in the covariates to the patient who were censored. So by giving the more weightage to this particular specific type of uncensored children, they will represent both themselves and similarly censored children. So by doing this, we also include, we will also model the children who were censored once they were lost to follow because of the stopping of medication. So that bias is actually minimized. So the next concept is propensity score overlap weighting. So basically between the Montelukast initiators and the LABA initiator, there might be multiple baseline characteristics that might be a confounding factor. So these are just examples. So to remove this baseline confounding factors, what they did is they asked a simple question, and based on that they developed a propensity score. The question is that what are the possibility of a chosen patient for him to receive either of the medication. If the possibility is more, for these patients more propensity score is given and they are weighted more. And the patient for whom the answer is either Montelukast or LABA. So they will be given a lesser weight, and based on this, the analysis is done. So by doing this, the baseline confounding bias due to various baseline characteristics are minimized. So coming to the patient enrollment flow chart, the initial patient children who were between 6 to 17 years were 1,20,132, out of whom 47,752 were Montelukast initiators and 72,380 were LABA initiators. So in the Montelukast group, 21,290 were excluded, in whom 13,992 were excluded due to prevalent LABA use, 7,614 were excluded due to history of any neuropsychiatric events, 1,588 were excluded due to they were living outside the Sweden before the start the index event, and 1,513 were excluded in view of any life-limiting condition. In the LABA group, 24,551 were excluded. Of them, 12,379 were prevalent Montelukast users, 11,912 were with the history of any neuropsychiatric event, 2,041 were living outside Sweden before the index event, 2,244 were with any life-limiting condition. After all this exclusion, 74,291 patients were included in the cohort. Of them, 47,829 were LABA group and 26,462 were Montelukast group. So this is the cohort flow. Based on the patients included, they were followed up as mentioned previously till the stopping of the treatment, switching or death, migration, or maximum of 1 year of follow-up. And the mean follow-up was 5.8 months and a maximum of 1 year. So these are the baseline characteristics, both unweighted and weighted cohort. So basically the unweighted cohort is the raw data, and the weighted cohort is a pseudo population created based on the overlap weighting. So if we see in the unweighted cohort, we can see a significant difference between the Montelukast group and the LABA group. If we take the example of age, we can see that the mean age is 11.2 in the Montelukast group, and the LABA group it is 12.9 with a significant standardized mean difference. But after the this overlap weighting, we can see that in all baseline characteristics, the between the two groups, the percentage is almost similar with no significant standardized mean difference. So the standardized mean difference of 0 means that it is an excellent balance between the two groups. Ideally, between 0.1 to 0.2, it's an acceptable, and more than 0.2, it is significant imbalance. So again, so these are the baseline characteristics that were for which overlap weighting was done: age, sex, calendar year, index season, disposable family income, parental education, municipality population density, indication, characteristics of healthcare setting of index prescription, and number of inhaled corticosteroid dispensing previously, type 1 diabetes, celiac disease, inflammatory bowel disease, atopic dermatitis, obesity. So the primary results. The overall risk of neuropsychiatric adverse events between the two groups in the weighted cohort. So if we see the total number of events between the two groups, in the Montelukast group, it is 310 events, and in LABA group, it is 566 events. With the hazard ratio in the Montelukast group is 0.99. So the secondary outcomes, if we see in the each secondary outcome, the hazard ratio in the anxiety is 0.79. In depression, it is 1.16. In sleep-related disorders, it is 0.93. In suicide and suicidal actions, it is 1.31. In disrupted control of activity, attention, and behavior, it is 1.27. Confusion and psychotic events, it's 0.51. So even though in certain groups it was 1.3 or 1.27, based on their confidential interval, it is not significant. So again, this is a cumulative incidence of any neuropsychiatric event and specific neuropsychiatric event for between the two groups in the weighted cohort. So the sensitivity analysis, like previously said, the sensitivity analysis was done for the alternate grace period and comparing the inverse probability of treatment weighing and overlap weighing and exclusion of censoring of weights and outcome defined by only diagnosis versus drug dispensing. In all the sensitivity checks, there was no significant hazard ratio in with or without the sensitivity checks, and the temporal analysis before and after FDA approval. Even with that, there was no significant change in the hazard ratio. The results remain consistent between after all the checks. So again, this is a forest plot showing between the two groups and between the primary and the secondary composite outcomes, which shows there is no significant hazard ratio. So coming to the critical appraisal, we use the CLASP tool. The CLASP tool has 3 sections. The first section is for the internal validity, the second section is for the results, and the third section is for the applicability. So coming to the first question, did the study address a clearly focused issue? So yes, because they had a clear population with a clear exposure, comparator, and outcome as previously discussed. So question number 2, was the cohort recruited acceptability? Again, the answer is yes, because the justification is they recruited from the their national wide studies population registers with a near complete coverage of more than 98% prescription capture, and also they used an incident user active comparator model. They excluded children with the prior neuropsychiatric events. That might be a limitation as it limits the generalizability. So question number 3, whether the exposure accurately measured. The answer is mostly yes. The objective prescription dispensing data, same assessment method for both groups, and the new user definition, which is clearly operationalized. These are the strengths, but the limitation is that just the dispensing may not always mean ingestion, and the adherence was not directly measured since it's a register-based cohort study. The next question is whether the outcome was accurately measured. Again, the answer will be partially yes. So the outcome assessment, like previously said, it's based on the specialist ICD diagnostic codes, and also they use the drug dispensing as proxy. So this has a high specificity for the high serious, serious events. But the limitation is that its sensitivity is limited for the mild symptoms and also for the internalizing symptoms. So whether the confounders were identified, yes, the key confounders, age, sex, asthma severity proxies, prior medication use, healthcare utilization, socioeconomic indicators, and calendar times were identified. But the unmeasured confounders can be family psychiatric history and subclinical behavioral symptoms. Whether it was addressed, yes. They used active comparator design with an overlap weighting for baseline confounding, and also they used an inverse probability of censoring of weights for post baseline selection confounding, and then sensitivity analysis was done for multiple factors as described previously. Whether the follow-up was complete enough. So the answer will be mostly yes. Since since it's a register-based follow-up and they had a good follow-up and minimal loss due to migration or death. Well, like previously discussed, the treatment discontinuation informative censoring was there, but they tried to mitigate it with an inverse probability of censoring of weights. Whether this follow-up was long enough, again, it depends on the outcome. For early neuropsychiatric events, it was okay, but for long-term psychiatric sequelae, this follow-up may not be long enough. So section B, what are the results? So like we discussed previously, the hazard ratio of 0.99 with absolute rates of 2.4 events per 100 patient year in both groups. So the precision of the result, it was good for primary outcome with a narrow confidence interval with excludes moderate harm. But for the rare outcomes, it is very difficult to say. Do you believe the result? Yes, there are some caveats. The supporting, the strengths were a large sample with robust design with the consistency across different sensitivity analysis. But for very serious outcomes, again, it is difficult to say. And due to unmeasured confounding, like we previously discussed, so again, these are the limitations. Coming to the section C, applicability, whether it can be applied to the local population in our country with, again, it is difficult to say. In systems where with similar prescribing patterns, it might be okay, but it is difficult to say. How does it fit with the other evidence? It aligns with the several large observational studies, but it does not negate the FDA warning. Implications for practice. So it is difficult to say based on one observational study, but we can say that montelukast is not contraindicated. It requires informed consent and monitoring, and it is. We cannot reflexively discontinue it. So these are the funding and support data that were disclosed. So it was publicly funded, investor initiated. It was not funded by any pharma company. So the methodological advantages: active comparator, new user design, overlap weighting with inverse probability of censoring of weighting, and national wide data were the strengths. And limitation was again the power for rare events, the outcome sensitivity, and residual confounding. Long-term psychiatric events and high-risk subgroups were the unknowns. So these are the limitations we discussed. So causality consideration. So no strong association to support causality. The consistency is that it aligns with the several methodologically strong studies, but contrasts with some signals in certain designs. Temporality, as treated design supports the temporal association if present. No early peaks identified. Biological plausibility, some animal and mechanistic data support the CNS penetration and plausible pathways, but human mechanistic evidence is limited. So conclusion is that this large, well-conducted observational study lowers the probability of a moderate causal effect, but cannot entirely exclude small and very large events. So the clinical implications, counseling points for family is that we'll have to explain the regulatory warnings based on the available studies, and we'll have to advise the caregivers to watch for new and worsening mood and behavioral changes, sleep patterns, suicidal thoughts, and inform them to stop the drug and seek urgent care if severe symptoms arise. And it can be preferred in certain specific phenotypes and where benefit might be likely. And caution should be taken in children with prior psychiatric history, and we'll have to document the baseline behavior and follow up within weeks of initiation. Again, the FDA boxed warning has recommended the restricted routine use for allergic rhinitis and with patients with minimal symptoms and with mental health side effects. This study does not provide strong evidence to overturn the regulatory caution, but it adds substantial pediatric data showing no detectable increase in composite neuropsychiatric adverse events. Regulators and guidelines may keep the warnings, but emphasize individualized risk-benefit assessment and standardized monitoring rather than blanket avoidance. So these are the future research directions: mechanistic studies to clarify CNS penetration and pathways linking leukotriene antagonism with mood behavior, high-risk subgroup studies in children with neurodevelopmental disorders and prior neuropsychiatric history and adolescents, longer follow-up and patient-reported outcomes, and linking with registry data and primary care reports, school reports, and validated symptom scales. Sibling and family control design, large target emulation, and triangulation across countries differing prescribing patterns, pooling and meta-analysis of robust pediatric cohort to gain precision for rare outcomes. So these might be the future research directions. Thank you. Thank you for the opportunity, sir, ma'am.
Okay. Thank you very much. That was a very nice presentation. And I think you highlighted the study very well with its limitations and its strengths. There are a few questions in the chat box, but before I get there, there was no evidence to suggest that they could monitor whether the patients took the drug or not. Was that looked into?
No, ma'am. They just were following the register, so it was very difficult to say whether they have taken it or not.
Because compliance sometimes becomes a problem in any of these chronic illnesses. The other thing I wanted to ask you was this was an observational study only, right? And is it good enough a study to identify neuropsychiatric, the causality of neuropsychiatric symptoms in just an observational study?
True, ma'am. The causality, it's very difficult to establish an observational study, but this is a good study since they included a very large sample size in a national-wide data, and for an adverse event, the sample size does provide some data, but definitely causality, it is very difficult to get from this kind of studies.
And is 6 months enough for such a study? For neuropsychiatric manifestations, probably can come. That's the reason why they took fresh cases, right?
Yes, ma'am.
That is the main purpose of taking fresh cases, because you can have manifestations before, later, whatever.
Yes, ma'am. True.
So these are the, I think, and I think Dr. Rawat has asked whether mild symptoms could have been missed.
True, ma'am. That is true. That is one of the limitation, and they didn't. I guess one of the reason they didn't wanted to follow up after the censoring done after the treatment was that it might dilute the data if censoring was not done after the discontinuation. So that's why they used the inverse probability of censoring weighting to counter for it.
I think, but overall, it was a good study because they kind of tried to reduce the bias, and it was a large sample size. The study had a lot of strengths as well, right?
Yes, ma'am.
Okay, Dr. Matthews, can we have your comments?
Yeah, thank you. First of all, I must compliment Dr. Shaktivel because this is a complicated paper and he has done a very good job. I will offer my comments after all the others have spoken because looking at the chat, there are some confusions which will need resolution. I just want to ask Dr. Shaktivel, is any part of your presentation made using chat GPT or anything?
Sir, I used AI models to create the pictures that actually the for the inverse probability sensor weighting and the overlap weighting. So I use for demonstrating the flow, sir.
Okay, nothing else, no? Nothing else is lifted off the internet and all?
I used multiple sources for mainly for the statistics actually, sir. I had several doubts regarding the several methods used. So for that, actually, I used several sources actually, including the articles and also like the general in the Google. So I multiple sources.
Yeah, okay. Thank you. Now we will defer to the other experts, and then finally I'll need 5 to 7 minutes to wrap this one up. Thank you, Dr. Indu.
Dr. Pramila, can we have your comments, please?
Yeah, I want to know actually, it is a retrospective study. So, if it is a forward study, we can always assess the neuropsychiatric illnesses in a better way. When we take the retrospective data, I don't know how much it was actually assessed to rule out or to include. My second comment is asthma and similar conditions, they are chronic conditions where the quality of life of the whole family, the child, and everybody is disturbed. Missing their school, missing the offices, not sleeping at night, not going to the playground, and things like that, social activities. So, all these patients already are very anxious, disturbed, they may not sleep, they may become irritable. So, do we actually relate these symptoms to the medicines used, or is it because of the condition per se? Because people in different studies have said yes and no for Montelukast. And definitely nobody is using Montelukast for years and years. You yourself has commented on that. It is used for particular conditions like seasonal or exercise induced or only once it is not under control? These are my main concerns. And then confounding factors will be similar for both. And I'm sure they were not using only LABA and only Montelukast. They must be using other asthma control medicines also.
Yeah.
Are they not using ICS at all in these conditions? I want to know what.
LABA cannot be anyway used single, I guess. They must have been using ICS for sure, right? There's a black box warning on use of LABA single. Dr. Saktivel, will you like to answer the concerns Dr. Patil has raised? Dr. Paul?
Yes, ma'am. So the first one, like ma'am said, it is very true, ma'am. So with all the family and all those, there might have like it is. I mean, that might also cause some confusions and. But the thing is, even with that, it has from this study, it has shown that the adverse events are actually not much compared with the LABA group. So that is one thing that we can take from that. But true, that is one thing, ma'am. And the second thing is, I couldn't get the second question, ma'am.
Neuropsychiatric problems in children with asthma, any which ways, because they are
Yeah.
not sleeping
But
well.
they are already disturbed. The whole family is disturbed. Quality of life is disturbed. It is also the financial constraint. So all these things are already disturbing the total family, and then to accept it as a long-term treatment also disturbs them. So how do we say that it is related to the Montelukast or to LABA or anything else? And in any case, in this study, LABA has been blamed more than Montelukast. Patients who are taking LABA were more disturbed rather. That means they had a chronic condition because of which they were disturbed and not because of the medicine.
Yes, ma'am. The event rates were more in the LABA group, ma'am. But when we compare it with the LABA group, that hazard ratio of 0.99, it shows that it was actually it is very similar in the both groups. And even though the number of events were more in the LABA group, but the patient, the cohort was also larger cohort. So that I think that could explain the larger event rates in the LABA group. But between the two groups, it is very similar. So that's what we can get from this study, ma'am.
One more point I want. Although Montelukast crosses the blood-brain barrier, that is the main hypothesis why we say that it is causing neuropsychiatric illnesses. ICS also does the same thing. So then I don't know. I am not really convinced that Montelukast is the main culprit for all these psychiatric illnesses. I am not convinced about that. I was never convinced. So that is my point, what I am trying to convey.
All right.
Instead of blaming the medicine, if it is because of the total condition of the patient and the family, that might be causing all these type of problems which we have been telling.
Sure. Thank you, ma'am. Dr. Sarath Balaji, would you like to throw some light on this, on the analysis for the paper or your expert comments in it? Dr. Balaji, are you there? Dr. Rawat, would you like to make a few comments?
Yes. First of all, I'd like to thank Dr. Saktivel for an excellent presentation. Uh, Now, this is an retrospective observational study, which makes it quite low on the hierarchy of strength of evidence. So, my first question is that what things in this study would make you upgrade this particular? Because to start with an observational study, which is retrospective, it starts at a very low level. So, can you highlight some important things in this study which will add to the strength and it will upgrade this particular study? My first question. Second question is that since it was a retrospective study and all the neuroscientific event, they were patient reported rather than they were seeked by the investigators. So I really don't think, because there would be a strong bias, because by that time there were lot of reports of neuropsychiatric events occurring. So until unless they are actively sought by the investigator or by the doctor treating, and they are depending upon patient getting reported that event. So there could be a strong bias, and the patient might not report it to the doctor concerned, or mild event might not have reported. So I think that there would be strong bias in this assessment. And how do you try to remove this particular bias, because this bias would really downgrade this particular study. So I think I've got this major two concern, that first of all, if there are anything which can upgrade this particular evidence, and second, how can you remove the bias?
Uh, Sir, two things that were strength of the study is that even though it's a retrospective cohort study, to remove the baseline confounding, they use this overlap weighting, that is number one, and to remove the post baseline bias, they use the this inverse probability of censoring of weights. So these two things are actually one of the strengths of this study. So that might be a point that might give strength to the study. Like you said, the second point, the minimal side effects might be missed and may not be reported. So that is very true, sir. So that is one of the weakness. But if because of this minimal side effects or early side effects, if they are stopping treatment, and that might also be like falsely leading us to believe that there is very minimal side effects. But for countering that particular aspect, they have again used this inverse probability of censoring of weights. So they have given more weight to the children who were uncensored, and based on the covariates, they have matched them with the people who have censored, and this additional weight given to them in the analysis actually try to remove this bias, sir. So other than that, the minimal side effects which were never reported is definitely one of the weak points for the study.
I agree with you, because this study has used very complex method which we have never come across. All these things to remove the confounding factors and all those things. So those all things are very complex. I think Dr. Matthew would show light on all those things. But are you aware of any specific steps which can apply on this study to upgrade it? Like this starts with a very low step. So are you aware of any specific points which you can apply on this study, and you can upgrade this evidence?
Other than the methods used in this study,
I think
since
sample size is very important, because this study had a very big sample size. So I think that is a very important factor which can come in the favor of study, and it can upgrade the evidence. I think that's one of the thing.
That is very true, sir. The large sample size is an additional strength. Again, since a retrospective cohort, it is again it was very difficult for them to, I guess, to add any more things. If it was an prospective, again they could have done a few more things for ensuring follow up, and that certain those kind of things could have improved the sensitivity for minor adverse events. And I'm really not sure what they could have done for internalizing symptoms. Again, sensitivity for them to be in an ascertainment from an specialist register is, again, it's a little difficult without an active follow-up. So I'm really not sure what's other statistical analysis that could be added to this that could improve the strength of the study.
Okay.
Thank you, Dr. Sir.
Yeah.
Thanks.
Thank you, sir.
Dr. Sarath Balaji, we need some pearls of wisdom from you as a mentor, and then
I'm
we'll
eager
go to Dr.
Well, I'm eager to hear the final words from Joseph, sir.
Okay.
Because the rest of the things
Over
were
to you,
covered
Dr.
exactly.
Okay. Even for the want of time, it would be. We will, of course, we will hear your pearls of wisdom as well. Dr. Joseph Matthews.
Okay. Thank you. Dr. Shaktivel, will you just put up this slide which has got that participant enrollment flow chart? Meanwhile, I will just make some comments. See, it is important for us to understand how this study has been done. Then many of the questions which have come up in the chat box, plus things in the minds of the participants, will get clarified. First thing to remember is the authors of this study have not come into contact with a single participant whose data is being reported. What then have they done? They have gone into a computer which records all the information of all the patients or citizens of Sweden, and asks that computer, please show us in this period to this period, how many people have received Montelukast in the age group of less than 18 years old. Then they also went and looked at another group who did not receive Montelukast, but rather than comparing it with receiving nothing, they looked at people who had received LABA. So all this is done is they have looked at people in the computer which are recorded or tagged as having received these two drugs. And how is the tagging done in the Swedish system? So every prescription there has to be put up onto a register or a database. So if the child's name gets flagged up, so he will be shown as having taken the thing. This is why Dr. Shaktivel very astutely said, having a prescription or being offered the drug does not mean that they actually have taken it or not taken it. Then, how did they find the neuropsychiatric manifestations? No child has been followed up over here. Again, the same database or register has been queried, asking it, please tell us amongst these children who have received LABA or Montelukast, how many in each group have got an ICD diagnosis which is compatible with a neuropsychiatric manifestation overall, plus those 6 subclasses that is there. This is all that has been done. But a lot of methodological refinements were used because they said that any child who had potentially already a history of some neuropsychiatric manifestation should not get miscounted because he already had it. So he couldn't have got it because of the medication. So all these were removed. So if you look at the chart over here, if you and you look at the people who have got this history, you see that about 16% of the population has got history of this neuropsychiatric event. This is in the third box from the top. On the left-hand side, it is 15.9%. On the right-hand side, it is 16.5%. Look at that. 1 in 6 children in the age group of 6 to 18 years has got some history of neuropsychiatric event. So that is a very important thing to remember. Remember that number. Then, because this is only a look into the database or computer, so we have no idea about the following things. We do not know if any of these children had asthma at all, because the computer has not been asked, are these children having asthma or not? The computer has only been asked, show us the children who have received Montelukast or LABA. Now, intuitively, we will believe that these children must have had bronchial asthma, but that intuition is wrong because somewhere in the results they will present that they looked at subgroup analysis between children with a diagnosis of asthma and without a diagnosis of asthma, and they found no significant differences. This means there are children in this database who are receiving either or both of these drugs who didn't have a diagnosis of asthma at all. So that is one big problem. Likewise, because it's only looking at the register or the computer, we don't know the baseline severity of the disease. And thirdly, we also don't know the indication for why these children have been prescribed Montelukast or prescribed LABA, which is even more interesting when it comes to the fact that neither their baseline diagnosis is known, nor their baseline severity is known, nor the very important thing which Dr. Paul raised, which is we don't even know how many of these were receiving ICS or not. There is one place in the results where it talks about prior ICS use, and that is in a very small minority of patients. Again, intuitively, we think that if they have got LABA, they must have had ICS, but it is actually not documented anywhere in this. So keeping these three things in mind, and the fact that the neuropsychiatric manifestations are also based on registry entries, now we have to interpret the results of these studies. Now, interestingly, if you look again at this chart, you see that in the Montelukast arm, there were only about some 47,700. 14,000 of these people have also been on LABA. And in the LABA arm, out of 72,300, about 12,400 of them are also in the Montelukast arm. Now, if the Swedish prescription system is based on the guidelines, which these authors have quoted, then there is no guideline which says that you will use ICS plus LABA plus Montelukast. But it looks like in either group, there is about 20% of the children overall. If you look at 120,000 as the total number of children, and you look at 13,992 plus 12,379, so that together is more than 20% of the children who are getting both Montelukast and LABA in a system which is supposed to be entirely based on prescription and things like that. So this raises a question about what is actually happening in that particular healthcare system. Now let us look at some of the results. Now the beauty of this study is exactly as Dr. Shaktivel said. They didn't compare it against no treatment with montelukast, but they used an active comparator. And all they have shown in this study is that the neuropsychiatric manifestation rate was comparable in the two arms. If there was a placebo or no treatment, then we would have had to see whether it was higher or not. But here all they have shown is comparability, which means that montelukast is probably not causing more neuropsychiatric events than the so-called LABA. But if you look at the exact percentages, it's about 2.5 per 100% years. So if you imagine that all children were followed up for 1 year, this means for every 100 children treated with montelukast, 2.5 of them are developing neuropsychiatric manifestation. And for every 100 children which have been followed up who have used LABA for 1 year, 2.5 of those are also developed. So if you imagine that the usual therapy duration for a child with chronic asthma is 6 to 12 months, this means for every 100 children treated, we should see 2 or 3 in either arm developing these neuropsychiatric manifestations. Authors have remained silent on this, but it is actually a very high percentage because it means for every 100 children you treat, 2.5 of them will end up with this within the period of 1 year. Then, another couple of things which they have mentioned in their own findings, which has not been highlighted in the presentation, is that they considered data in 5-year epochs because they did it from 2007 till 2021. So they had the privilege of looking at 5-year epochs, and they found that with each 5 years, the prevalence or incidence of this neuropsychiatric manifestation has gone up, which is interesting because two things could be happening. One is that more people are reporting to the healthcare system, at least to obtain prescriptions or a diagnosis of neuropsychiatric manifestation, independent of what is going on in the background, which means either physicians have become more sensitized or it means that there is some background event happening in the Swedish system because of which more children are getting diagnosed. And this is likely to happen because some of the manifestations like sleep disorders and things like that we all know in the last 20 years, the numbers have doubled, tripled, quadrupled, and probably gone up much more times simply because of greater sensitivity amongst the physician population. Then, of course, one interesting thing that they found is if you looked at the baseline reasons or the baseline characteristics of children who got montelukast, they were completely different from the children who got LABA. And therefore, this imbalance between the two is exactly why a lot of statistical tweaking had to be done to try and make the groups comparable. So what has been done is they have looked at the probability, they call it here propensity, that a child in either arm would have received the opposite treatment and then try to balance it between the two. So this means a lot of outliers, a lot of children who were actually receiving something else would have all been excluded. So now those exclusions, the number is not known, unfortunately, and the impact of that on the overall result is also known. And the final point here is that we don't know the reason for why these children stopped medication. So their way of calculating children who came off treatment is any child who did not fulfill the prescription of either drug and with a grace period of 60 days. And that 60 days was in a sensitivity analysis also tweaked to 30 days and 90 days, found to be the same. So it is not necessary that these are children who stopped the drug. It is only children who stop refilling the prescriptions. And finally, last but not the least, Dr. Shaktivel very correctly said that cause and effect relationship cannot be proven in this study. So what have we actually learned from this study? Excellent, nicely, statistically, robustly done study. Basically an analysis of available data from their computerized databases with all its flaws and limitations showed that the proportion of children who went on to develop neuropsychiatric manifestations if on montelukast. Why they're on montelukast? Reason for the baseline diagnosis, nothing we know, is not different from the children who were on LABA, and that's about 2.5 per 100 person years. Now we come to the nub of the whole thing. What do we take from this for our own practice or for our own learning? I think from our own learning, we compliment Dr. Shaktivel. He's done a great job of looking at all this complex data, trying to simplify it for us. So it has been a great learning experience. Thank you, Dr. Shaktivel, for that. Are we in a position now to say that Montelukast is free from the risk of neuropsychiatric side effects? Absolutely not, because all that this data has shown is that it is comparable to the LABA in a cohort of children whose indications itself we do not know what it is. So the authors also have acknowledged this, and they have tried to piggyback their findings with the results of many other findings, but also mentioned, to be fair to them, two studies, one from South Korea and one from somewhere else, wherein they found the opposite association to what they have described. So I think our big learning point is great paper for a journal club, not enough for us to base or change our practice, as often happens with these retrospective database review kind of papers. And we will have probably more answers to come in the months and years to come. Thank you very much. We can stop the slide sharing. Huh? Thank you.
Excellent analysis. Some things where I think which you all even probably didn't look into. Dr. Joseph Matthews, we can never have enough of you. I think we are going to continue this journal club for, I think, years to come, for us to learn and be as perfect as you. Dr. Sarath Balaji, would you like to make a comment?
Over, everyone.
Over. We've all been bowled over. Excellent, excellent. I mean, it was simply wonderful what the way you analyzed it, Dr. Matthews. Dr. Ajay Kumar, you've been silent. Would you like to make a comment?
No, ma'am, no comment.
Dr. Matthews, you've left us all speechless.
Yes, ma'am.
No, but we have to compliment Dr. Shaktivel, who has taken great pains, studied the paper, gone into the literature to try and identify all the complexities, made some nice graphics for us to simplify, and then done a very thorough critical appraisal. So I think the compliments are due to him. So you really did a good job, Dr. Shaktivel.
Thank you, sir.
Yes,
Thank you very
yes,
much, sir.
Dr. Pramila, you wanted to say something.
Yeah, I still want to say, like in the retrospective study, was it like in all those patients, were they actually recording all these anxiety, depression, symptoms like that? Because they have asked the computer, right? But were they also listing them in their retrospective data? How did they say that they had so many symptoms in their retrospective data? Like in India, we are not really, at least I am not recording always unless there is something major. So how did they collect that data in the retrospective, that whether they had the symptoms or whether they did not have the symptoms?
Uh,
Dr. Matthews?
Ma'am, they did two things, ma'am. So how did they collect this data is only based on the when this patient comes to their primary care providers or doctors and they report their symptoms and it is documented in their registers, ma'am.
So
So
it was
whatever,
only reporting, it was only who reported, but it
yes,
was not always there that somebody might be having some symptoms, but parents never noticed and they never sort of reported it also. So that
yes,
means
ma'am.
there were lots of
Yeah,
missing out the findings.
yes, ma'am. True. So only thing is, whoever has stopped the treatment because of this early symptoms, instead of just directly reporting them, only for those specific population, this inverse probability of censoring of weight could have helped a little. Uh, like you said, whoever has not reported, whoever has had mild events, though they might have been missed, ma'am.
Okay. Thank you. Thank you so much. That was a very important question. Thank you so much. And thank you, Dr. Rawat, Dr. Ajay Kumar. I think this is the last session
Yes,
of.
last session. Yeah.
But I'm sure you'll be there to attend all the next
Yes, surely. I can't miss it. Surely I'll be there.
because we cannot miss you either. So we want you to
Thank
be
you.
there.
Thank
Thank
you.
you so much. I think we wind this session up right now. And thank you once again for holding it for this whole year. It has been a great learning and a huge learning curve. But one thing I realized that we need to do more of it. After today's analysis of Dr. Matthews, I think we've not had enough of it. Thank you so much. Thank you, everyone.
Thank you.
Thank you,
Good night,
sir.
all.
Okay.
Good night.
Thank you, sir. Happy New Year, sir.
Yeah.
Happy New Year to all of you, sir, ma'am.
And a Merry Christmas.
Yes, ma'am. Merry Christmas also.
Yes. Thank you. Bye-bye.
Good night, ma'am.
Good night. Good night.
Good night, ma'am. Good night.